Welcome back. In this lesson, we begin step 1 of the diagnostic pathway, recognizing cardiac amyloidosis, specifically ATTR-CM. Amyloidosis can manifest in multiple organ systems, including the heart, kidneys, nerves, soft tissues, gastrointestinal tract, liver, spleen, and lungs. Once symptoms raise clinical suspicion, an initial workup should include lab tests, ECG, echocardiogram, and organ-specific assessments based on the presentation. Suggestive lab findings include elevated NT-proBNP and troponin, cardiac, proteinuria, renal, hypoalbuminemia, renal, GI, elevated alkaline phosphatase, hepatic, cardiac. A 24-hour urine collection for total and monoclonal protein is especially useful when AL amyloidosis is suspected. Now that we've reviewed the early warning signs and red flags for cardiac amyloidosis, the next question is, who's actually at risk? Because recognizing who to screen is just as important as recognizing what to look for. Both types of transthyretin cardiac amyloidosis result in similar cardiac phenotypes, but they differ significantly in their cause, demographic distribution, and genetic background. Let's begin with wild-type ATTR-CM. This form is age-related and not caused by a genetic mutation. You might know it by its older name, senile systemic amyloidosis. Autopsy studies show that up to 25% of people over age 85 have evidence of wild-type ATTR deposits, making it far more common than many clinicians realize. And in hospitalized elderly patients with heart failure and preserved ejection fraction, or HFpEF, up to 13% may actually have unrecognized ATTR-CM. Now let's turn to hereditary ATTR-CM. This form is genetic. It's caused by autosomal dominant mutations in the TTR gene. Over 150 different mutations have been identified so far. Each one carries its own pattern of organ involvement and age of onset. One of the most important variants is VAL122I, also written as V122I. This mutation affects 3 to 4% of African Americans and is associated with a more severe cardiac phenotype. Without treatment, the median survival is just 2.5 years. Let's now compare how the demographics and risk factors differ between these two types of ATTR. Starting with wild-type ATTR-CM, it's overwhelmingly more common in men. In fact, the male-to-female ratio is reported as high as 25 to 50 males for every 1 female, especially in older populations. So, if a man over 60 or a woman over 70 presents with unexplained cardiac symptoms, particularly heart failure with preserved ejection fraction, wild-type ATTR should be considered in the differential. For hereditary ATTR-CM, the age of onset varies depending on the mutation, but it typically appears between the 40s and 60s. Some examples: valine 30-methionine, or V122I, most common in individuals of African ancestry. T60A more frequently found in Irish descent. Late-onset V30M seen in non-endemic regions, including parts of Europe and North America. Both forms, wild-type and hereditary, are more common in men, though we still don't fully understand how sex affects progression or outcomes. Wild-type ATTR is due to age-related misfolding of the normal transthyretin protein. It has no genetic mutation and tends to affect the heart exclusively. By contrast, hereditary ATTR is caused by a mutation in the TTR gene passed down in an autosomal dominant pattern, meaning a single copy of the gene is enough to cause disease. And importantly, hATTR often involves multiple organs, including the nerves, gastrointestinal tract, and kidneys, in addition to the heart. So why does this matter in clinical practice? Because when we understand the underlying type of ATTR and the demographic patterns, we're better equipped to screen appropriately, identify high-risk patients earlier, and refer for the right genetic or cardiac testing. Now let's shift our focus to what actually brings these patients into the clinic, because while ATTR-CM may begin silently, it doesn't stay silent forever. Let's start with what's most common. The single most frequent presentation is heart failure, and more specifically, heart failure with preserved ejection fraction, or HFpEF. Roughly 68% of diagnosed ATTR-CM cases present with this syndrome, especially among older adults. But here's the catch: cardiac symptoms are often not the first signs of the disease. In fact, one of the earliest red flags is bilateral carpal tunnel syndrome, and it can precede cardiac involvement by 10 to 15 years. Tissue biopsy during carpal tunnel release has revealed amyloid deposits in up to 37% of cases. Other orthopedic signs include lumbar spinal stenosis and biceps tendon rupture. These are often linked to wild-type ATTR and reflect amyloid deposition in connective tissues, particularly in older adults. Now let's talk about hereditary ATTR, which often begins with non-cardiac signs. You may see peripheral neuropathy, including burning, numbness, or tingling in the feet. Autonomic dysfunction symptoms like orthostatic hypertension, abnormal sweating, or bladder issues. Gastrointestinal symptoms such as chronic diarrhea, early satiety, or unexplained weight loss. And if the patient is of African descent, we need to be especially alert for the valine 30 methionine mutation. This is the most common TTR variant in this population and is associated with a particularly aggressive cardiac phenotype. One of the most important red flags we encounter is this: unexplained HFpF with left ventricular hypertrophy, LVH, in a non-hypertensive patient. This constellation should immediately raise suspicion for cardiac amyloidosis. And finally, a positive family history of variant ATTR or known TTR mutations should always prompt genetic counseling and predictive testing. Early diagnosis in family members can be life-saving. 2. Comparison of organ involvement in different types of transthyretin amyloidosis. Let's now shift our focus to the heart, specifically how transthyretin amyloidosis impacts cardiac function in both its wild-type and hereditary forms. Although these two subtypes differ in genetic origin, they converge pathophysiologically at the myocardium. In both cases, the heart becomes progressively infiltrated by transthyretin amyloid fibrils, leading to a form of restrictive cardiomyopathy that is often debilitating if left untreated. This infiltration isn't a secondary byproduct, it is the disease itself. As amyloid builds up within the myocardial walls, it compromises the heart's ability to contract and relax, disrupting both systolic and diastolic function. Once this structural damage progresses beyond a certain point, it becomes irreversible, underscoring the need for early recognition and timely intervention. The pathological cardiac effects, such as wall thickening, conduction abnormalities, and eventual heart failure, are shared across both subtypes, despite different underlying causes. Let's explore a key pathological feature seen across both wild-type and hereditary transthyretin amyloidosis: restrictive cardiomyopathy, or RCM. In transthyretin amyloid cardiomyopathy, this condition results from progressive myocardial infiltration by amyloid fibrils. As deposition increases, ventricular compliance is impaired, filling pressures rise, and diastolic dysfunction emerges, typically with a preserved left ventricular ejection fraction, LVEF, in the early stages. Unlike hypertrophic or dilated cardiomyopathy, where wall thickening or chamber dilation is driven by myocyte hypertrophy or volume overload, RCM due to amyloid infiltration does not alter the cavity size. Instead, the ventricular walls become stiff and non-compliant, limiting proper diastolic filling. RCM, consistently seen in both wild-type and hereditary forms, has emerged as a frequent cause of unexplained restrictive physiology, particularly in older adults. Studies confirm it as a shared and defining feature across genotypes. In both types, the underlying pathophysiology converges. Amyloid fibrils infiltrate the myocardium, inducing mechanical stiffness and progressive dysfunction. This pattern is diagnostically critical as it signals an infiltrative systemic disease, not merely conventional heart failure. The animation now displayed shows amyloid deposits layered within the myocardium. These fibrils thicken and stiffen the ventricular wall, explaining the restricted filling pattern that defines RCM in ATTR-CM. Let's take a closer look at heart failure with preserved ejection fraction in the context of transthyretin cardiomyopathy. HFpEF is a frequent early manifestation of a TTR-CM and is often under-recognized, particularly because it mimics more common conditions like hypertensive heart disease. Many patients, especially elderly men with WTA-TTR or middle-aged adults with HA-TTR, present with unexplained HFpEF as an initial clinical clue. It results from myocardial amyloid infiltration, which impairs ventricular relaxation and raises filling pressures. This leads to diastolic dysfunction, increased left atrial pressure, pulmonary congestion, and reduced cardiac output reserve. Because the clinical picture often overlaps with hypertensive heart disease, especially in older WTA-TTR patients, symptoms such as dyspnea, fatigue, or exercise intolerance are frequently misattributed to age-related changes. However, a ATTR-CM differs distinctly in both pathophysiology and imaging features, with clues like low-voltage ECG, apical sparing on strain imaging, and preserved EF despite restrictive physiology. Recognizing HFpEF in the right clinical setting should prompt consideration of an infiltrative cardiomyopathy like ATTR-CM, especially when conventional explanations fall short. Let's take a closer look at the structural remodeling that occurs in transthyretin cardiac amyloidosis. What you're seeing on screen isn't traditional hypertrophy. In a TTR-CM, ventricular wall thickening results from amyloid infiltration rather than muscle growth, a phenomenon known as pseudohypertrophy. This infiltration stiffens the myocardium and reduces compliance, leading to diastolic dysfunction. As a result, even though the heart appears to contract normally, many patients develop heart failure with preserved ejection fraction. A hallmark echocardiographic finding is apical sparing, where the apex retains contractility while the base and mid walls are impaired. This strain pattern is highly specific for ATTR-CM and supports the diagnosis. Now here's something unique. Despite the thickened myocardium, ECGs often show low QRS voltage. This mismatch, known as the voltage mass discrepancy, should always raise suspicion for cardiac amyloidosis. But the story doesn't end with the ventricles. The atria are also targets of amyloid infiltration, which can lead to atrial enlargement, electrical instability, and a high burden of atrial fibrillation, particularly in HA-TTR cases. Importantly, this atrial dysfunction contributes to elevated thromboembolic risk, even in patients without typical risk factors. That's why many individuals with ATTR-CM require lifelong anticoagulation. To summarize, these key structural and electrical clues should raise immediate clinical suspicion: pseudohypertrophic wall thickening, apical sparing on strain echocardiography, voltage mass discrepancy on ECG, atrial remodeling and fibrillation, and high thrombotic risk. These features are consistent across both wild-type and hereditary ATTR-CM, and early recognition is critical for diagnosis and timely intervention. Let's now turn to the conduction system and how it's affected in transthyretin amyloid cardiomyopathy. In both wild-type and hereditary forms, amyloid can infiltrate the heart's electrical pathways, disrupting the sinus node, AV node, and his Purkinje fibers. This disruption leads to bradycardia, atrioventricular, AV block, and bundle branch abnormalities, particularly in advanced disease stages. These conduction issues aren't just incidental, they're clinically significant. Many patients eventually require permanent pacemakers. In fact, according to data from the THAOS registry, up to 50% of patients with ATTR-CM receive pacing devices during the course of their disease. Wild-type ATTR tends to present with conduction disease later in the disease course, while in hereditary ATTR, especially the valine 30-methionine variant, electrical disturbances often emerge earlier and more prominently. This animated video shows what's happening. In a normal heart, the electrical impulse flows seamlessly through the conduction system. But with amyloid infiltration, those signals are delayed or completely blocked, resulting in arrhythmias that may not respond to medical therapy alone. Let's take a closer look at left ventricular hypertrophy, or LVH, in transthyretin amyloid cardiomyopathy. In both wild-type and hereditary ATTR, wall thickening is commonly observed on imaging. But here's the key distinction. This thickening doesn't come from increased muscle mass. It's the result of amyloid infiltration into the myocardium, a phenomenon we call pseudohypertrophy. This stiffened myocardium impairs the heart's ability to relax and fill properly, contributing to diastolic dysfunction and the clinical picture of heart failure with preserved ejection fraction, especially in older adults. A hallmark finding on strain imaging is apical sparing, where the apex of the heart remains relatively preserved, while the basal and mid-segments show reduced longitudinal strain. This pattern is highly suggestive of a TTR-CM. And here's another diagnostic clue, the voltage mass discrepancy. Despite increased wall thickness on echocardiography, the ECG often shows low QRS voltage, a mismatch that should raise immediate suspicion for amyloidosis. So when you see thickened walls, preserved EF, low ECG voltage, and apical sparing, think beyond hypertensive heart disease. These are classic indicators of an infiltrative cardiomyopathy, like ATTR. Let's take a moment to discuss a subtle but telling sign in transthyretin cardiac amyloidosis, pericardial effusion. Mild pericardial effusions are relatively common in advanced stages of ATTR-CM. While these effusions are typically small and asymptomatic, they may serve as a marker of disease burden, especially in patients with aggressive genotypes like valine 122 isoleucine or early-onset valine 30 methionine. In wild-type ATTR, these effusions are almost always mild and rarely cause clinical concern. But in hereditary ATTR, particularly in advanced disease or rapidly progressing variants, fluid accumulation can occasionally be more pronounced. So while pericardial effusion isn't a hallmark finding, its presence should raise clinical awareness. In the right context, it may be a subtle clue pointing to the extent or progression of cardiac involvement in ATTR. Now let's turn to the right side of the heart and how transthyretin amyloidosis can lead to right-sided heart failure and pulmonary hypertension. Infiltration of the right ventricle by amyloid fibrils reduces both compliance and contractility. This contributes to systemic venous congestion, manifesting clinically as peripheral edema, ascites, and jugular venous distension. Compounding the issue is postcapillary pulmonary hypertension, often triggered by elevated left atrial pressures due to diastolic dysfunction. This form of PH worsens right ventricular strain and is considered a negative prognostic factor in a TTR-CM. Importantly, both wild-type and hereditary ATTR can present with these complications. While their underlying mechanisms may differ, right-sided heart failure and PH reflect advanced myocardial involvement in either form. In transthyretin amyloidosis, whether wild-type or hereditary, cardiac involvement presents with a distinct set of structural, electrical, and functional abnormalities, all driven by amyloid infiltration of the myocardium. These abnormalities include restrictive cardiomyopathy, heart failure with preserved ejection fraction, and pseudo-hypertrophic thickening of the left ventricular wall. Other key features are atrial dysfunction, atrial fibrillation, conduction disturbances, right ventricular failure, and the presence of pericardial effusion. Recognizing this constellation of findings is critical. It requires a multimodal approach, integrating imaging tools with detailed clinical evaluation. Early and accurate diagnosis has never been more important, especially with the availability of disease-modifying therapies such as tafamidis and antisense oligonucleotides, which can significantly alter the disease course if initiated promptly. Now that we've explored the hallmark cardiac features of transthyretin amyloidosis, it's equally important to understand the conditions that can mimic or be mistaken for ATTR-CM. This next section, titled Clinical Mimics and Differential Diagnoses, highlights the diagnostic challenges clinicians face when a TTR-CM presents like other more common cardiac diseases. By recognizing these overlapping presentations and distinguishing features, healthcare providers can reduce misdiagnosis, avoid delayed treatment, and initiate disease-modifying therapy at an earlier stage. The clinical presentation of transthyretin cardiac amyloidosis, or a TTR-CM, is often deceptively similar to a range of more common cardiac diseases. This phenotypic overlap is a key reason for the frequent diagnostic delays and underdiagnosis seen in both wild-type ATTR especially among elderly patients, and early-stage hereditary ATTR. In many cases, ATTR-CM is mistaken for or coexists with conditions such as aortic stenosis, hypertrophic cardiomyopathy, hypertensive heart disease, or AL amyloidosis. Additional clinical mimics include dilated cardiomyopathy, peripartum cardiomyopathy, toxic cardiomyopathy, stress-induced cardiomyopathy, and even cardiac sarcoidosis. This broad range of potential lookalike conditions underscores the importance of maintaining a high index of suspicion, particularly in patients with unexplained heart failure symptoms, increased ventricular wall thickness, or preserved ejection fraction. Let's start with one of the most important and often overlooked clinical overlaps: aortic stenosis and transthyretin cardiac amyloidosis. Recent studies have shown that 16% to 33% of elderly patients undergoing transcatheter aortic valve replacement, TAVR, also have concurrent ATTR-CM. Why is this important? Because in these patients, valve replacement doesn't always resolve the symptoms. That's due to the persistent restrictive physiology caused by amyloid infiltration, even after the aortic obstruction is relieved. One major red flag: low flow, low gradient aortic stenosis paired with unexplained left ventricular thickening, especially in patients without significant hypertension. In these cases, clinicians should have a high index of suspicion for a TTR-CM. To confirm the diagnosis, bone scintigraphy with technetium-labeled tracers like 99-MTC-PYP or 99-MTC-DPD provides a non-invasive and highly specific method for identifying transthyretin amyloid deposits. Recognizing this dual pathology, aortic stenosis and coexisting ATTR-CM, is essential. Without proper identification, patients may be misclassified as treatment failures, when in fact they need targeted therapy for amyloidosis alongside standard valvular care. A particularly important diagnostic challenge occurs when transthyretin cardiac amyloidosis mimics hypertrophic cardiomyopathy, commonly referred to as HCM. Although a TTR-CM typically causes concentric thickening of the ventricular wall, studies show that up to 25% of patients with wild-type ATTR present with a septal dominant pattern of thickening, a hallmark traditionally linked with HCM. This overlap in imaging features can lead to misdiagnosis, delaying appropriate treatment. In fact, histological analysis has uncovered amyloid deposits in patients who underwent septal myectomy for presumed HCM, only to be diagnosed with a TTR-CM afterward. That's why tissue biopsy and amyloid typing are essential, particularly in patients with atypical features or who fail to respond to standard HCM therapies. So, in any older adult with unexplained left ventricular hypertrophy, especially when blood pressure is normal or there's a family history of amyloidosis, ATTR-CM should remain high on the diagnostic radar. Let's compare a TTR cardiomyopathy with one of the most common mimics, hypertensive heart disease. At first glance, both can present as heart failure with preserved ejection fraction, or HFpEF. But underneath, they're fundamentally different, both in pathophysiology and imaging appearance. In hypertensive heart disease, the driving force is chronically elevated blood pressure. This leads to true myocyte hypertrophy. The heart muscle thickens as a direct response to pressure overload. By contrast, a TTR-CM features concentric wall thickening due to amyloid protein infiltration, not from muscular hypertrophy. This is what we call pseudohypertrophy. It mimics structural changes, but the underlying process is entirely different. Now here's the catch: many patients with ATTR-CM are normotensive or even hypertensive, and that can be a red flag, especially in older adults with wild-type ATTR where hypertension might not even be present. That's a key clinical clue, and one that's often overlooked. Echocardiography might show thickened walls, but remember, in a TTR-CM, this thickening is due to amyloid, not muscle mass. Unless ATTR-CM is actively considered, it's easy to mislabel the findings as hypertensive remodeling. Clinically, HFpEF in a TTR-CM is defined by preserved ejection fraction, typically 50% or greater, alongside impaired ventricular relaxation and elevated diastolic pressures. Unlike typical HFpEF, ATTR-CM is often accompanied by conduction disturbances and arrhythmias. This overlap in symptoms delays diagnosis in many patients. And by the time we recognize what's truly going on, organ damage may already be advanced. The takeaway? When you see heart failure with preserved ejection fraction, especially in older normotensive individuals, keep a ATTR-CM high on your differential. Let's now discuss an important differential diagnosis, AL amyloidosis, which can often mimic transthyretin cardiac amyloidosis, or ATTR-CM. Both conditions can lead to a restrictive cardiomyopathy, but AL amyloidosis tends to progress more aggressively and is associated with higher early mortality. This makes timely and accurate differentiation absolutely essential. Unlike ATTR-CM, which is treated with transthyretin stabilizing agents like tafamidis, AL amyloidosis requires chemotherapy, making the choice of treatment radically different. So how do we distinguish between them? We rely on laboratory testing, including serum and urine immunofixation, free light chain analysis, and confirmatory tissue biopsy. These samples are then subjected to mass spectrometry to definitively type the amyloid. In clinical practice, ruling out AL amyloidosis must always be a priority when evaluating any suspected cardiac amyloidosis, due to the therapeutic urgency and distinct prognosis associated with each type. Let's talk briefly about the overlap between ATTR cardiomyopathy and dilated cardiomyopathy. In its advanced stages, ATTR-CM may evolve to resemble dilated cardiomyopathy, or DCM. This means the left ventricle becomes dilated and systolic function starts to decline. Clinically, this can mimic idiopathic DCM, making it harder to distinguish the two conditions. The challenge here is that if ATTR-CM isn't considered early, especially in older adults, there's a significant risk of misdiagnosis. What looks like typical DCM could in fact be advanced amyloid infiltration. That's why maintaining a high index of suspicion for ATTR-CM is essential, even in patients who present with dilated chambers and reduced ejection fraction. Now let's compare two important but often confusing conditions: transthyretin amyloid cardiomyopathy and idiopathic dilated cardiomyopathy. Although both can present with symptoms of heart failure, their origins and clinical behaviors are very different. ATTR-CM is caused by amyloid fibril deposition in the heart muscle, either from wild-type transthyretin or due to hereditary mutations like VAL122-EEL. It usually affects older adults, typically over 60 years old, and starts with preserved ejection fraction, progressing gradually over time. DCM, by contrast, is often idiopathic or familial and typically presents in younger individuals between their 30s and 50s. It starts with reduced systolic function and a markedly dilated left ventricle. Structurally, ATTR-CM shows concentric thickening of the walls, a pseudo-hypertrophy due to amyloid deposits, while DCM features thin or normal walls with significant ventricular dilation. On electrocardiogram, ATTR-CM may show low QRS voltage and conduction blocks despite wall thickening. In DCM, the QRS voltage is typically normal and left bundle branch block is more common. Symptomatically, ATTR-CM may include classic signs of heart failure with preserved ejection fraction progressing to reduced ejection fraction. Patients may also report neuropathy or bilateral carpal tunnel syndrome, red flags that are rarely seen in DCM. Imaging can help. Echocardiography or cardiac MRI in ATTR-CM often reveals apical sparing and diffuse gadolinium enhancement, while DCM typically shows mid-wall fibrosis or a more focal pattern. If you perform technetium-based bone scintigraphy, like 99-MTC-PYP or DPD, it's usually positive in ATTR-CM, but negative in DCM. Serum testing for monoclonal proteins will be negative in wild-type ATTR, but it's essential to rule out AL amyloidosis. And finally, genetic testing can help confirm the diagnosis. In hereditary ATTR-TTR mutations like VAL122I are common. In idiopathic DCM, you might find mutations in genes like LMNA, TTN, or MYH7. Now let's turn our attention to toxic cardiomyopathies, an important differential when evaluating patients with suspected ATTR cardiomyopathy. Certain cardiotoxic agents, such as anthracyclines, alcohol, and some chemotherapy drugs, can cause myocardial dysfunction that closely mimics ATTR-CM. This includes similar imaging findings like left ventricular wall thickening, diastolic dysfunction, and even preserved ejection fraction in the early stages. Clinically, the presentation can overlap significantly. Patients may exhibit symptoms like fatigue, dyspnea, and reduced exercise tolerance, mirroring those seen in transthyretin amyloid cardiomyopathy. So how do we tell them apart? A thorough patient history is essential. Always assess for previous exposure to cardiotoxic medications, long-term alcohol use, or environmental toxins. These historical details are critical in distinguishing toxic cardiomyopathy from amyloid infiltration. Without careful history taking, toxic cardiomyopathy may be misdiagnosed as ATTR-CM, especially in patients without known genetic mutations or red flag features of amyloidosis. Let's now talk briefly about peripartum cardiomyopathy, or PPCM, and how it can sometimes be confused with a TTR cardiomyopathy. Although rare, a ATTR-CM can occasionally resemble PPCM, especially when it presents with biventricular heart failure. Both conditions may involve symptoms like fatigue, shortness of breath, and fluid overload. But there are important differences that help us distinguish the two. PPCM typically occurs in younger women, and specifically during late pregnancy or within the early postpartum period. That timing is critical for diagnosis. In contrast, a ATTR-CM is more common in older individuals, often men, and has a very different pathophysiological basis involving amyloid fibril deposition in the heart. So while the clinical presentations can overlap, the age, sex, and timing of symptom onset are key clues that help guide us toward the correct diagnosis. Let's talk about how cardiac sarcoidosis can sometimes resemble a TTR cardiomyopathy. Both conditions may present with restrictive cardiomyopathy features and conduction abnormalities such as AV block or bundle branch block. However, their underlying pathophysiology is quite different. Sarcoidosis is driven by granulomatous inflammation, which leads to patchy myocardial involvement. In contrast, a ATTR-CM is caused by amyloid fibril deposition that diffusely infiltrates the myocardium. Now, how do we tell them apart? Advanced imaging plays a key role here. FDG-PET scans are particularly useful. In sarcoidosis, you'll typically see focal or patchy FDG uptake, reflecting active inflammation due to granulomas. On the other hand, a ATTR-CM generally shows little or no FDG uptake because amyloid deposits are metabolically inert. Additionally, cardiac MRI and endomyocardial biopsy can help confirm the diagnosis. MRI may show late gadolinium enhancement, but the pattern differs, and biopsy can definitively identify granulomas in sarcoidosis or amyloid in ATTR. Understanding these distinctions is critical to avoid misdiagnosis and ensure patients receive the right treatment. Let's now turn to stress-induced cardiomyopathy, also known as Takotsubo cardiomyopathy. This condition can occasionally mimic ATTR-CM, particularly during acute episodes. Patients may present with symptoms of heart failure and characteristic apical ballooning on imaging, features that can initially resemble cardiac amyloidosis. However, one major differentiating factor is reversibility. Takotsubo cardiomyopathy typically resolves within a few weeks, which can be confirmed through follow-up echocardiography or cardiac MRI. In contrast, a ATTR-CM is a progressive chronic disease marked by ongoing amyloid infiltration. So, if you see dramatic recovery on repeat imaging, that strongly favors Takotsubo over a ATTR-CM. Monitoring disease progression or lack thereof is essential in making the correct diagnosis. Before we wrap up, let's recap what we've covered. In this lesson, we explored the many ways transthyretin amyloid cardiomyopathy can mimic other cardiac conditions. From hypertensive heart disease and dilated cardiomyopathy to rare presentations like Takotsubo syndrome and peripartum cardiomyopathy, a ATTR-CM is a master of disguise. We've highlighted how imaging, clinical history, and specialized testing like scintigraphy, cardiac MRI, and genetic screening play vital roles in distinguishing ATTR-CM from its lookalikes. And we've emphasized the importance of considering red flags like low voltage on ECG, apical sparing on strain echo, and family history in patients with unexplained heart failure. Recognizing these patterns early and thinking beyond conventional diagnoses can be life-changing for patients, especially those with hereditary forms like the VAL122 mutation. So as clinicians, let's continue raising suspicion for ATTR-CM in the right contexts, use the full toolkit of modern diagnostics, and never underestimate the value of a thorough clinical evaluation. Thank you for watching. In the next lesson, we'll move beyond the heart and explore extracardiac manifestations of transthyretin amyloidosis, key early warning signs that often precede cardiac symptoms. I'll see you there.